Hi, welcome to General Pathology sessions. We are going to discuss about amyloidosis in this video. So, amyloidosis is actually a group of disease. Amyloidosis is not a single disease; it is a group of disease, and amyloid formation is a part of this disease. No, we should know what is amyloidosis, what group of disease show this amyloidosis, and what is this amyloid? What exactly is amyloid? Why it is deposited? How it is deposited? So amyloidosis is a long essay type of question in your university grade examinations. Now let's see what is amyloidosis. As I told you, amyloidosis is a group of disease. So many disease in where you can see a material called amyloid. Amyloid is a extracellular material, some material which is formed in our body. Okay, so amyloid is an extracellular deposition of a fibrillar protein. It is actually a fibrillar protein made of fibrils or fibrous protein, and it is insoluble. Means that is insoluble in our body fluid, so it will be present as an extracellular solid body. Okay, that is a proteinaceous substance that is called amyloid, and there's a peculiar staining of this amyloid. They will be having a specific morphology, specific biochemistry, and a specific staining pattern. Means that the amyloid will appear in a specific morphology, and it has a specific chemical composition. There is a specific chemical composition for this amyloid and a specific protein or staining properties or physical nature. Okay, and each amyloid will vary in their composition. There is a lot type of amyloid, they vary in the composition. Now amyloid is first described by Rokitansky in 1842, but it was named by Virchow. The term amyloid was given by Virchow. Amylo is means something related to starch. Amyloid means starch like. Okay, amylon, it is derived from the word starch or starch like. Now, amyloids are named according to alphabets. Okay, it is named as A, L, A, etc. We will see in your coming videos. So, what is meant by this amyloid AL? Means that A is for amyloid. The first word A is for amyloid, and the second word L. Okay, and the second word is the type of the protein it has, type of the chain it has, whether it is derived from light chain. Okay, so we say AL. Okay, so that is how it is named. And what is the physical and chemical nature of this amyloid? What is exactly amyloid? Amyloid is exactly a type of protein. Okay, it is a type of protein, and each amyloid has a different chemical composition. Now we see all forms of the amyloid will look similar. They will look similar. They have a specific morphology and they have a equal staining pattern. All will appear equal, but they will have a different chemistry. The fibers present in or the chemical component, the protein component present in it will be different. So chemically there are two types of amyloid based on the protein present in it. There are two types. There is fibrillar protein and non-fibrillar protein. There are two types of protein present in an amyloid. There is fibrillar protein which makes the fibrous part, and there is non-fibrillar protein. So 95% of the amyloid is fibrillar protein, and rest 5% is formed by the non-fibrillar protein. Now let's see what are the fibrillar protein and how it look like. Fibrillar protein that makes up 90%, and they are formed of delicate dispersed fibers. Okay, non-branching fibers. And what is the size of these fibers? They are nearly 7 to 10 nanometers. So they are fibrils. Okay, it is looking like fibrils. Okay, they are randomly dispersed non-branching fibers. They have no branches, and the size of each fibril is nearly 7.5 to 10 nanometer. Randomly dispersed non-branching fibers. Okay, and they will wind on each other. They will wind on each other, and they will form a bundle. Okay, that's what a fibrillar protein does. Now, this fibrillar protein can be divided into two, that is your AL protein and AA protein. AL is amyloid light chain, and AA is amyloid associated protein. Now, let's see what is AL and AA. Now, AL protein mainly it is the immunoglobulin light chain protein. AL protein, and it is derived from mainly from the plasma cells. Okay, it is mainly derived from the plasma cell and mainly seen in the primary amyloidosis. So, if the AL protein, the protein is nothing but your immunoglobulin. Okay, the protein here is a light chain immunoglobulin. There are two types. There is kappa chain and the lambda chain. Okay, there are two light chains which are derived from the plasma cell. There can be kappa and lambda. So AL protein is nothing but the immunoglobulin, which is the amyloid, which is derived from the immunoglobulin protein, mainly formed by the plasma cell. And this light chain can be kappa chain or lambda chain, and mainly is in the plasma cell diseases, as it is formed from the plasma cell. In all plasma cell diseases, you can see majority your AL protein can be seen, or in primary systemic amyloidosis also you can see AL protein. Coming to AA protein, it is derived from a serum protein. It is called serum amyloid associated protein. So it is not from your plasma cell. Here it is derived from the serum. Okay, it is derived from the serum protein, that is serum amyloid associated protein. And here it is mainly seen in the secondary amyloidosis. Okay, now coming to what are the other proteins which are seen in the amyloid. What are the other proteins other than the AL and AA? You can see transthyretin, your alpha A beta 2 microglobulin, okay, your amyloid beta peptide, your endocrine amyloid forms, and your prion amyloid of prion proteins. Okay, all these are different types of amyloid proteins, fibrillar proteins. Now coming to the non-fibrillar protein, which are the non-fibrillar protein, that is only 5% of the amyloid material. 95% is your fibrillar protein. We have seen the AL, AA, your transferrin, your beta 2 microglobulin. All this makes a 90%, 95%. 5% is made by non-fibrillar protein. They are amyloid P, apolipoprotein, sulfated glycosaminoglycans, and other small proteins. So these are not that important, but you should know the headings at least. That is amyloid P protein, or the P component. Amyloid P component is a non-fibrillar protein. Apolipoprotein E, your sulfated glycosaminoglycans, okay, and other proteins. Now coming to the pathogenesis of amyloid, how a amyloid is formed. Now you can see that you see amyloidosis. In amyloidosis, there is a production of amyloid. There is two methods, two ways of the production of amyloid. Okay, now you can see there is a problem, there is a stimulus. Okay, and if the stimulus is acting on your B cells, causing B cell lesions. Okay, B cell lesions of your plasma cell lesions, your B lymphocytes. Okay, you know that your plasma cells are the mature form of your B lymphocytes. Okay, your plasma cells in your body, they are the mature forms of or differentiated forms of your B lymphocyte. Now we have a stimulus which is acting on this B lymphocyte or acting on this plasma cells. Though there is a proliferation of these plasma cells, that condition is seen in your myeloma cases, in conditions like your multiple myeloma or other plasma cell neoplasms, okay, or B cell neoplasms. So here, what is the triggering factor? What is the cells which are causing here? They are the plasma cells. Now these plasma cells, they will proliferate and they make, what is the function of these plasma cells? They are going to make immunoglobulin. Immunoglobulin. The function of the plasma cell is to make immunoglobulin. Which immunoglobulin they are going to make? They are making the immunoglobulin lambda or immunoglobulin kappa lambda chains. Okay, so immunoglobulin light chains are made. Now there is a neoplasm. There is excessive production of this what your plasma cell. The plasma cell make excessive immunoglobulins. More and more immunoglobulins are produced. More and more kappa and lambda chains are produced. Some of these kappa lambda chains, our body will try to remove. The macrophage will come and eat the kappa lambda chains, and they will try to digest this kappa lambda chains. Some of these immunoglobulins are trying to be excreted through urine, that is called Bence-Jones protein. Okay, so the Bence-Jones protein are immunoglobulins. Excessive immunoglobulins are presenting in our body. There is a stimulus that activate your B cells, that activate your plasma cells. There is myeloma in your body. There is a condition called multiple myeloma or plasma cell neoplasm. The proliferating plasma cells, okay, tumorous plasma cells, they are going to make more and more immunoglobulins. This immunoglobulins contain your kappa and lambda light chains. More and more immunoglobulins in our body. Our body tried to remove these immunoglobulins. One thing they can do is that remove through the urine. Okay, some immunoglobulins go through the urine, that's called Bence-Jones protein. Now, some immunoglobulins will be eaten up by the macrophages. They will try to digest it, but they can't digest it completely. So, that is called partial digestion, partial degradation. So, partial degradation, after partial degradation, they are deposited in the tissue. Insoluble amyloid is deposited in the extracellular space, that is called AL amyloid. Now, you know what is AL amyloid. A light chain amyloid, which is mainly produced due to your plasma cells, mainly seen in the plasma cell lesions. Okay, that is AL amyloid. Now, some other condition like your infections, chronic infection. Now, no, it is not due to plasma cell. In our body, there is chronic infection or Mediterranean disease, okay, familial Mediterranean disease, such conditions. There is activation of this macrophages, and the macrophages, okay, along with the certain interleukins, the cytokines, due to inflammation, there is an increased interleukin. This macrophages will secrete SAA proteins or serum associated amyloid. There is a secretion of serum associated amyloid from the liver cells. Okay, so from where this is coming, due to chronic inflammation, the serum associated amyloid is coming through the liver cells, and that is partially digested by the reticular endothelial cells. The reticular endothelial cells will try to partially degrade, but they can't also degrade this, and they are deposited in the extracellular space as AA amyloid. Now I think you understood in the previous slide we discussed about AL protein and AA protein. The SAA protein, okay, the kappa and the lambda chain, the plasma cell dyskaryosis we have discussed. Okay, this is a table we have discussed. Now coming to that image here, now you understood how you should study that table, how that amyloid is formed. You're both AL amyloid and AA amyloid. Now coming to deposition of amyloid, okay, so whenever there is a disorder of your plasma cells, or whenever there is an inflammation, there is increased production of this amyloid. So disorders like your multiple myeloma, your B cell neoplasm or plasma cell diseases, there is excessive immunoglobulin production, and there is production of immunoglobulin, and this immunoglobulin is partially degenerated by your macrophages, but they can't completely digest it, and there is a production of this AL amyloid. This AML amyloid will combine with other non-fibrillar components. Okay, this fibrillar amyloid combine with your non-fibrillar components. Okay, non-fibrillar components, your fibrillar AL amyloid will combine with the non-fibrillar components like your amyloid P component or your GAG, and they combine to form the complete amyloid. Now this AA amyloid, it is related to SAA amyloid, that is synthesized by the liver, okay, in response to the cytokines, and this case this is seen in chronic inflammatory condition, and this AA amyloid is also deposited, okay, just like your AL amyloid. Now what about amyloidosis? So we know that the conditions where you can see amyloid deposition, all the conditions where you can see amyloid deposition is called amyloidosis. Amyloidosis is a group of condition where this amyloid is formed. So it can be primary or secondary, it can be classified according to cause, the primary cause, secondary cause. We can be classified according to extent. It is localized in one area or generalized, okay, localized or generalized, or it can be classified into the AL amyloid, AA amyloid, that is a biochemical property which amyloid is deposited, or it can be classified according to the clinical location where it is located, where it is deposited. Now coming to the classification, you can see this is a concise table of your classification. See, go through this table. We have concised the classification. See, first one is your systemic or generalized amyloidosis, means amyloid is deposited throughout the body. It can be primary, secondary, or hemodialysis associated. Okay, it is a hemodialysis associated. It is primary, secondary, or dialysis associated. Primary, we have plasma cell lesions. Okay, your primary one is plasma cell lesions. And what type of amyloid is deposited in plasma cell lesion? the light chain amyloid, the kappa or lambda light chain, that is AL type. And where it is deposited? In the systemic way. Many organs it will be deposited, that is heart, bowel, skin, nerve, kidney, and most of the internal organs it will be deposited. Coming to secondary amyloidosis, it is due to chronic inflammation. The chronic inflammation is the cause. And what kind of amyloid? This amyloid is coming from the SAA protein. This amyloid is coming from the SAA protein. It is formed by the liver cell. And which type of amyloid is this? It is AA type of amyloid. So where it is deposited? In the liver, the spleen, the reticuloendothelial system, your liver, spleen, bone marrow, etc. Now there is a type of amyloidosis which is called hemodialysis amyloidosis, which is related to the renal failure, which is associated to the dialysis. So here the amyloid beta 2 microglobulin type is seen. Okay, the beta 2 microglobulin type is seen, and this is hemodialysis associated. It is mainly deposited in the joints. Okay, in the joints. Now coming to another one, that is the head-of-familial type. It's a rare type where it is seen in hereditary polyneuropathies. In hereditary neuropathies, HTTR type amyloidosis is seen. In familiar Mediterranean fever, amyloidosis AA type is seen. And rare hereditary forms, you can see other types of minor amyloidosis. Okay, so this is not that important. At least you should know the primary, secondary type. Okay, 1 and 2. It is very important. We have already discussed. Coming to the localized amyloidosis. Here it is localized to a single area. Okay, not all the areas are deposited. It is localized to a single area. There is certain types of senile cardiac amyloidosis. It deposits ATTR type of amyloid mainly in the heart. That way it is senile cardiac. There is senile cerebral, which is mainly deposited in the cerebral blood vessels, and A beta and APPR, the type of amyloid is deposited. So this is not that important, but you should know there is localized form of amyloidosis like your endocrine and the tumor forming amyloid. Okay, there are different types of amyloidosis. Now coming to the primary systemic amyloidosis and secondary amyloidosis, we are concerned about the primary amyloidosis and secondary amyloidosis. The primary amyloidosis that is formed by the plasma cell, we have discussed. The primary amyloidosis which is formed by the plasma cell defect or your B cell neoplasms. What is there in primary amyloidosis? Primary amyloidosis, which type of fibrils are formed? The AL fibrils are formed. It can be systemic or localized. Okay, mainly it is systemic. Okay, mainly is a systemic. In primary amyloidosis, it is AL type of fibrils are deposited, and most commonly it is systemic. Okay, and 30% of the cases it is due to your plasma cell disorders, and 70% cases there is no evident B cell proliferative disorders. And primary amyloidosis is mostly seen in your heart, kidney, your systems. Okay, most of all your systems, your oral cavity. And how it is treated? It's a plasma cell neoplasm. So we are giving a chemotherapy. The chemotherapy is given against your plasma cell. Okay, plasma cell. So treatment can be by chemotherapy drugs against the plasma cells. Okay, and the survival, median survival is nearly very less. Okay, it is about 1 year. The survival rate is very poor. Okay, because it's a B cell neoplasm. Coming to the secondary or reactive amyloidosis. Here it is due to, not due to a B cell neoplasm, it is due to some chronic inflammation in the body. Some kind of reactive chronic inflammation in the body. And which type of amyloid is formed? It is AA amyloid. It is due to some chronic inflammation, some chronic cancers, or some internal reasons. Okay, some chronic inflammatory conditions and some tumors. Okay, and it can occur in any age, it can occur in any type because of the chronic inflammation. Okay, and that is also, this is a type of amyloidosis we see in children. Okay, it can occur in children. Now secondary amyloidosis, how you treat? You should treat the infectious part, which is the chronic inflammation present in the body. Treat for the cause. Okay, the cause is treated, and there is a good prognosis for this, because we can reduce the level of the amyloid process in the blood by treating the chronic inflammation. So this is the microscopic feature of the amyloid. If you see in the HNE staging, if you take a tissue which is having this amyloid, can you see that these are areas which are seeing pink eosinophilic material. They are homogeneous, structureless pink eosinophilic hyaline material. Can you see? All these are pink eosinophilic material. They are nothing but your amyloid. Okay, amyloid. And if you see, there's a special stain for the amyloid. To check whether it is amyloid, we can use a special stain. The special stain is called Congo red. Okay, so we have a tissue here. There is a homogeneous structureless material we are seeing in the H&E stain, and we do want to know that, oh, whether it is amyloid or not. Okay, what special stain you can use for amyloid? Amyloid, for checking amyloid, we are using a special stain called Congo red. Now we stain it with the Congo red, and how you will see? You will put it in a polarizing microscope. Okay, there's a special type of microscope. In a polarizing microscope, you can see this amyloid stained with the Congo red will give you a green color. That is called apple green birefringence. Okay, it is very simple procedure. You take the section, stain it with the Congo red, you put it in a polarizing microscope and see under the microscope. Can you see we have an amyloid here? Okay, which is stained by a stain called Congo red stain, and we are seeing the same thing in a polarizing microscope. Can you see the amyloid present in will be giving a green color? It is called apple green birefringence. This is a peculiar property of this amyloid. So what are the staining characteristics of amyloid? If you see in the H&E, it is pink hyaline structureless homogeneous material. We can also stain with some other stain called crystal violet. Okay, crystal violet, it will give a pink in color. We can stain it with the Congo red. Now we have seen it will give a pink red color, but we see in a polarizing light it will give apple green birefringence. And other stains which are thioflavin T. Okay, you can use thioflavin T, thioflavin S. Stain it with thioflavin T and thioflavin S and look under fluorescent microscope. Okay, you have to see in a fluorescent microscope, then you can see fluorescence from that object. Okay, you can see immunohistochemistry. That is another technique. We use antibodies against this your amyloid. These antibodies will go and bind to the amyloid, and it will give a signal, and we can get that signal. If you get that signal, it means that our antibody has gone and bound to the amyloid, so there is amyloid. Okay, so this is immunohistochemistry. And what are the other morphological features of amyloid? Is that most commonly where the amyloid deposits. Where should check for amyloid? Mostly in between the vascular areas. Okay, vascular areas mainly near the blood vessels. Okay, amyloid is deposited, and in between the cells, extracellular areas, not inside the cell. It is seen in the extracellular areas and mostly in the basement membrane region. Okay, near to the blood vessels. Mostly amyloid is seen near to the blood vessels. And in amyloidosis of kidney, okay, mainly it is found in secondary amyloidosis. Amyloidosis in secondary amyloidosis, it mostly affects your kidneys. Okay, now if you see this image, it's a gross image of a kidney which has undergone amyloidosis. So how it appear grossly is that it will appear pale, waxy, translucent. Okay, the kidneys will be appearing like a pale, waxy and translucent. And if you see the microscopy of this kidney, can you see that the amyloid is deposited on the basement membrane of the glomerular capillaries? Okay, in the near the blood vessel, near the basement membrane of the glomerular capillaries, you can see amyloid deposits. See one here and one here. See large amyloid deposits. Okay, large amyloid deposits in the kidney. Okay, and what it causes, if the amyloid is deposited, it will cause narrowing of the blood vessels. The blood vessels will be narrowed. Okay, and the kidney architecture is lost. Okay, it will distort the glomerular capillaries. So coming to the amyloidosis of the spleen, how amyloidosis can be seen in the spleen? In amyloidosis of the spleen, it can be seen in two morphologies or two patterns. One is called a sagospleen, another is called a Laplacious spleen. See, the main difference between a sagospleen and a Laplacious spleen is the spleen enlargement is present or not, and where exactly the amyloidosis is seen, in which pattern it is deposited. So here in sagospleen, the spleen is not enlarged. Okay, the splenic enlargement is not there. You can see the amyloidosis when you cut open the spleen. You can see the amyloidosis. They appear as small grains or small nodules. Okay, they're resembling small nades. Can you see here? There is small nodules of this amyloidosis. Okay, and where they begin, they start at the white pulp region of the in their spleen. Okay, and they come start in the white pulp and they come extending towards the other areas of the spleen. Coming to lardaceous spleen, here the spleen is enlarged, lardaceous. Okay, so there is marked splenomegaly. Spleen is enlarged, and when you cut open that spleen, what you can see is that it is not small nodules. It is in a wide area, or it is spreading like a map like areas. Okay, map like areas are seen, and where the deposit is involving, it's involving the red pulp region. Okay, in the red pulp region, and it is then extending. So it's the main difference between a sago and a lardaceous spleen. Now, how to diagnose? We have already seen how to diagnose an amyloidosis. You can use your H&E stain, you can use your Congo red, you can use your crystal violet, you can use your thioflavin. Okay, you can use immunohistochemistry. So many diagnostic method. You can do a tissue diagnosis by so many method, or you can what a confirmatory diagnosis can be seen using a kidney specimen. You take the biopsy, you can see the confirmation. You can also do a fine needle aspiration. If you can take a biopsy, you can do a fine needle aspiration. Means you put a needle, you take out the material, you stain it with Congo red, and you can see under a polarizing microscope. What will you see? If you take some material of this amyloid using a needle from a nodule, you can take out some material, you put on a slide, you stain it with Congo red, and you use a polarizing microscope. What color you can see? You can see an apple green birefringence. Apple green birefringence. Okay, all these are the or the test. Okay, it is your Congo red test. Okay, this we have already discussed. All the thing we have already discussed how to check for Congo red strain. Now we can do an in vivo Congo red test also. Means in vivo means in a living tissue we can push some Congo red. We can inject some Congo red in the vein of a patient, and I can see whether this Congo red is going and depositing in the amyloid. What if there is amyloid in the tissue? Amyloid in this person. See, if I am having amyloidosis, I am putting some Congo red into my vein. So if there is amyloid in the body, this Congo red will go and attach to the amyloid. So what happens? The Congo red in my blood will reduce. Okay, the Congo red, I am putting 100 ml of Congo red in my blood. Okay, in my body there is amyloid. So what happens? This 100 ml amyloid will go and bind to the cells, bind to the amyloid, and after some time, if I check my blood, there will be 10 ml of amyloid, then 10 ml of Congo red. Means that rest 90 ml has bound to the amyloid. My body has amyloid. Okay, so that's how you can check for the in vivo Congo red test. And other tests like your protein electrophoresis, bone marrow aspiration, or immune electrophoresis, all these tests can be done. So what about the prognosis, which is better? Okay, there is usually the prognosis for amyloidosis is very poor. The primary amyloidosis is very much poor because it is due to the B cell neoplasms or plasma cell neoplasms. We are giving chemotherapy, it is very poor. Okay, and in secondary amyloidosis, we have a better prognosis than the primary. Okay, anyway, it is a bad prognosis, but it is having a better outcome and than primary because it is due to some chronic inflammation, right? If we control the chronic inflammation, we will get a better prognosis. So that's all about your amyloidosis. See you in the next video with a new topic. Thank you.